First question. A pregnant client comes to the office for her first prenatal examination at 10 weeks. She has been pregnant twice before. She has a 3-year-old girl child born at 39 weeks, 2-year-old boy child at 36 weeks. Using the GTPL system, which of the following is the correct format? So coming to the GTPL system, G for gravida, that is the number of pregnancies including the current. T for term pregnancy, that is a pregnancy carried to term or carried to gestational week 37 weeks, completed 37 weeks. Preterm, that is a preterm pregnancy and it includes gestational period between 20 to 36.6 weeks. And A for abortion, the abortion in total. The abortion, if the abortion occurs after 20 weeks, it is counted as preterm. And L for leaving, that is the number of leaving children. So in the question, this is her third pregnancy. So coming to the G will be 3, G3. And term pregnancy, so the girl child was born at 39 weeks. So and 2-year-old boy child was born in 36 weeks. So term pregnancy is only 1. So the score of the T is 1. So G3, T1. P preterm, 1 preterm pregnancy is there. So P1 and A 0, that is there is no history of any abortion. And L leaving children, 2 leaving children is there. So the score is G3, T1, P1, A0, L. G3, T1, P1, A0 and L2. So the answer is option C, 31102. Next question. When teaching a mother of 4-month-old with diarrhea about the importance of preventing dehydration, the nurse would inform the mother about the importance of feeding her child. Which of the following should be included in the diet of the child? Option A, fruit juices. B, diluted carbonated drinks. C, soy-based lactose-free formula. D, regular formulas mixed with the L-trite solutions. Answer is C, soy-based lactose-free formula. Fruit juices will aggravate the diarrhea. Diluted carbonated drinks contains high carbohydrate. It will also aggravate the diarrhea. And regular formulas contains lactose, which will also aggravate diarrhea. But soy-based lactose-free formula, which will reduce the stool output and decrease the duration of diarrhea in most of the infants. Next question. A client with a diagnosis of C4 injury has been stabilized and is ready for discharge. Since this client is at risk for autonomic dysreflexia, the nurse should instruct the patient and his family to assess and report which of the following signs and symptoms. Option A, dizziness and tachypnea. Option B, circumaural pallor and lightheadedness. Option C, headache and facial flushing. Option D, pallor and itching of face and neck. Answer is C, headache and facial flushing. Autonomic dysreflexia is a potentially life-threatening syndrome involving an abnormal overreaction of autonomic nervous system. So it is a life-threatening syndrome. The main reason is that the abnormal overreaction of the autonomic nervous system. What is happening here is that there will be a painful sensory input, or it occurs in response to a stimulus, usually bladder or bowel distension, and it is usually originated below the level of the neurological injury, which will result in vasoconstriction and the elevated blood pressure. So usually it happens after a spinal cord injury at or above the 6th thoracic vertebrae, and it is a neurogenic emergency and it should be treated immediately in order to prevent a hypertensive stroke. And it is usually accompanied by a severe headache, bradycardia and facial flushing along with pallor, cold skin and sweating in the lower part of the body. So autonomic dysreflexia is a life-threatening syndrome, and it occurs as a result. It occurs in response to some of the painful sensory input or in response to a stimulus, usually bowel or bladder distension, that is originating below the level of the neurological injury, and which can finally result in vasoconstriction and elevated blood pressure, and it usually happens after a spinal cord injury at or above the 6th thoracic vertebrae. It is a neurogenic emergency and should be treated immediately, and the signs and symptoms include the severe headache, bradycardia and facial flushing, along with pallor, cold skin and sweating in the lower part of the body. Other names of autonomic dysreflexia is autonomic hyperreflexia, hypertensive autonomic crisis, sympathetic hyperreflexia, autonomic spasticity, paroxysmal hypertension, mass reflex, viscero-autonomic stress syndrome. These are other names for the autonomic dysreflexia. The most common noxious stimuli that trigger autonomic dysreflexia includes issues affecting bladder, bowel and skin. Coming to the bladder trigger, it includes mainly the bladder distension, bladder spasms, bladder stones, urinary tract infection. So these are the bladder trigger that can lead to autonomic dysreflexia. And coming to the bowel trigger, mainly it is a bowel distension. And coming to the skin trigger, it includes pressure injury or bed sore, cuts or bruises, rashes, clothing that is too tight, lumpy or baggy, and itch that can't be sensed or scratched. What we have to do in this autonomic dysreflexia case is that we have to sit the person upright with their legs dangling and remove any tight clothing or constrictive devices, which will help to lower the blood pressure. And we have to identify the trigger and we have to remove it, and we can use some rapid acting drugs such as nitrates, hydrolysine, labetalol or nifedipine in order to lower the blood pressure. Next question. A 35 weeks pregnant woman is undergoing a non-stress test. During the 20-minute examination, the nurse notes 3 fetal movements accompanied by accelerations of the fetal heart rate, each 15 beats per minute and lasting for 15 seconds. The nurse interprets this test to be option A non-reactive, B reactive, C positive, D negative. Answer is B reactive. So what is non-stress test? So the main purpose of the non-stress test is that this test determines the fetal well-being and evaluates the fetal heart rate in response to fetal movement. Fetal heart rate in response to fetal movement. And the procedure is that an external transducer and tocodynamometer are applied to the abdomen, and we will position the patient on left lateral position and will monitor for 20 minutes. We have to instruct the mother to press a button every time when she feels fetal movement, which is used as a reference point. Instruct the mother to press a button whenever she feels a fetal movement. So how we will interpret the results? So the test is said to be reactive, means the fetus is healthy. That is, we will be getting 2 or more fetal heart rate accelerations of at least 15 beats per minute lasting at least 15 seconds from beginning of acceleration to end during a 20-minute period. That is, we will be monitoring this fetal heart accelerations for 20-minute period, and in this 20-minute period we should get 2 or more fetal heart rate accelerations, and it should be at least 15 beats per minute and should last at least for 15 seconds. Then we can say that the non-stress test is reactive and the fetus is healthy. And if it is non-reactive, means there is no acceleration or acceleration of less than 15 beats per minute or lasting less than 15 seconds during 40-minute observation. So another more test is that this contraction stress test. It determines the fetal ability to tolerate labor and determines fetal well-being. Here the fetal ability of the fetus to tolerate labor is determined, and thus determines the fetal well-being. And the procedure is that an external fetal monitor is attached and the uterus is stimulated to contract by administration of diluted doses of oxytocin until 3 palpable contraction with a duration of 40 seconds. So in non-stress test, we are not using any drugs, just we are placing an external transducer and will tell the mother to click the or press the button whenever she feels any movement, fetal movement, and we are checking for the fetal heart accelerations. In this contraction stress test, we are administering diluted doses of oxytocin until we are getting 3 palpable contraction with a duration of 40 seconds. After that, we will monitor the fetal heart rate decelerations. So results is that the test is said to be negative, means there is no late decelerations. Here we are checking whether there is any fetal heart rate deceleration is there. Opposite of acceleration is deceleration. That is, in negative control stress test, there will be no late deceleration of the fetal heart rate followed by administration of oxytocin. That means the fetus is ready to tolerate the labor. Positive contraction stress test means late deceleration of fetal heart rate. Late deceleration of fetal heart rate means the fetus will not be able to tolerate the labor. Next question, the chest compression and ventilation ratio should maintain in neonatal resuscitation. The chest compression and ventilation ratio should maintain in neonatal resuscitation. Option A, 3:1 ratio of 90 chest compression and ventilation every 30 seconds. 1:1 ratio of 90 chest compression and ventilation every 90 seconds. Option C, 3:1 ratio of 60 chest compression and ventilation every 20 seconds. Option D, 2:1 ratio of 90 chest compression and ventilation every 45 seconds. Answer is 3:1 ratio of 90 chest compression and ventilation every 30 seconds. So the neonatal resuscitation guidelines recommend a 3:1 compression ventilation ratio. Cardiac compressions should be delivered at a rate of 90 per minute, synchronized with ventilations at a rate of 30 per minute to achieve a total of 120 events per minute. So 90 per minute cardiac compressions and 30 per minute ventilations, total 120 events per minute. Next question, intramuscular injections in neonates should give in dorsogluteal muscle. Option B, vastus lateralis muscle. Option C, gluteus maximus muscle. Option D, deltoid muscle. Answer is vastus lateralis muscle. Next question, what is the normal plasma osmolality ranges in adult? Option A, 260 to 270 milliosmoles per liter. Option B, 280 to 290 milliosmoles per liter. Option C, 320 to 330 milliosmoles per liter. Option D, 300 to 310 milliosmoles per liter. Answer is option B, 280 to 290 milliosmoles per liter. What is plasma osmolality? The serum or plasma osmolality is a measure of the different solutes in plasma. It is a measure of the different solutes in plasma. And the reference ranges for serum osmolalities are as follows. For adult, it is 285 to 295 milliosmoles per kg H2O or 285 to 295 millimoles per kg. And for children, it is 275 to 290 milliosmoles per kg water. Next question, which of the following clinical feature is not seen in a client with a dengue hemorrhagic fever? Option A, thrombocytopenia. Option B, leukocytosis. Option C, lymphadenopathy. Option D, fever. Answer is option B, leukocytosis. So thrombocytopenia, lymphadenopathy, fever, these symptoms, signs and symptoms can be seen in dengue hemorrhagic fever. The definition of dengue hemorrhagic fever consists of 4 clinical criteria. They are fever, a hemorrhagic tendency, thrombocytopenia and plasma leakage. So in hemorrhagic tendency, there will be spontaneous bleeding and there will be a positive tourniquet test result. And the thrombocytopenia, the platelet count will be less than 1 lakh cells per cubic millimeter. And the plasma leakage, it is shown by pleural effusion, ascites or more than 20% hemoconcentration. And the main clinical features includes nausea, vomiting, rash, aches and pains, and a positive tourniquet test, leukopenia, and the warning signs will be abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleeding, lethargy, restlessness, and liver enlargement. Next question, a pediatric patient would receive 500 ml DNS through burette infusion set in 5 hours. Calculate the current fluid drops per minute. Option A, 100 macro drops per minute. Option B, 100 micro drops per minute. Option C, 80 macro drops per minute. And D 80 microdrops per minute. In pediatric infusion set, the drop set will be in the form of microdrop set, and so the answer may be 100 microdrops per minute or 80 microdrops per minute. So how we will be calculating is that drops per minute is equal to volume to be infused divided by time into drop factor. So we know that the drop factor is 60. In case of pediatric infusion set, drop factor will be 60. So here the volume given is that 500 ml and the time is 5 hours. When we are converting this 5 hours to a minute, we have to multiply the time into 60, that is 5 into 60, and the drop factor is 60. And while calculating, we will get the answer as 100, and the answer is 100 microdrops per minute. Next question, which of the following ECG finding would be seen in a patient with the kidney failure with potassium level 6.3 milligram per deciliter? So we have to find the ECG finding in the hyperkalemia case. Options are flattened T wave, B peaked T wave, C ST segment elevation, D ST segment depression. Answer is B peaked T wave. So we can see some ECG findings in some of the disease condition. First one, hyperkalemia. The ECG waves in hyperkalemia will be narrow and tall peaked T wave. So peaked T wave, flattened P wave, prolonged PR interval, widened QRS complex. Peaked T wave, flat P wave, prolonged PR interval, widened QRS complex. In hypokalemia, P wave will be peaked P wave, prominent U wave, depressed ST segment and inverted T wave. Peaked P wave, prominent U wave, depressed ST segment depression and inverted T wave. And coming to hypercalcemia, there will be short QT interval, and in hypercalcemia there will be long QT interval. Next question. While doing Weber test by tuning fork assessment and checking for vibration sense, which one of the following frequency tuning fork is commonly used for screening hearing impairment? Options A 128 Hz, option B 2056 Hz, option C 512 Hz, option D 1028 Hz. Answer is option C 512 Hz. So Rinne's and Weber's tests are simple tuning fork tests used to screen for the presence of conductive and sensory neural hearing loss. So Rinne and Weber test are the simple tuning fork test used to screen for the presence of conductive and sensory neural hearing loss. So what is happening in the Rinne's test is that at first we will place the vibrated tuning fork on the, that is base of the vibrated tuning fork on the mastodon, and confirm whether the patient is able to hear the vibration, and also tell him that inform you whenever you are not able to hear the sound. And if the patient is not able to hear, then move the fork in front of the ear, that is 1 centimeter away from the ear, and ask the patient is able to hear or not. If the patient is able to hear the sound, it means that air conduction is more than bone conduction. So if we are placing the tuning fork on the mastodon, we are checking the bone conduction, and placing the tuning fork on the tuning fork in front of the ear, here we are checking the air conduction. So if the patient is able to hear the vibration of tuning fork which is present in front of the ear, it means that it is normal, that is air conduction is more than the bone conduction, that is patient can hear fork at ear. And if the patient is having any conductive loss, it means the patient will not be able to hear the sound in front of the ear. That means more bone conduction is more than air conduction. Patient will not hear fork at ear. And what we will be doing in Weber test is that we will place the base on the midline of the forehead, and normally we will be able to hear the vibrations on both ears equally. And if we are having any conductive loss, we will be able to hear the vibrations only on affected side, that is one side, affected side. And in case of sensory neural loss, the vibration will be heard to better means normal or better hearing side. So sensory neural loss will occur as a result of any pathology involving the inner ear cochlea or the auditory nerve, and in conductive hearing loss, it is because of any cause that limits the amount of external sound from gaining access to the inner ear. For example, cerumen impaction. And in case of mixed, a combination of conductive and sensory neural hearing loss. So in this slide, you can see the described procedure of the Rinne test, that is, place a vibrating 512 Hz tuning fork firmly on the mastoid process. This test bone conduction, confirm the patient can hear the sound of the tuning fork, and then ask them to tell you when they can no longer hear it. When the patient can no longer hear the sound, move the tuning fork in front of the external auditory meatus to test air conduction. Ask the patient if they can now hear the sound again. If they can hear the sound, it suggests air conduction is better than bone conduction, which is normal. And in case of a Weber test, normal is that the sound is heard equally in both ears, and in sensorineural hearing loss, sound is heard louder on the side of the intact ear, and conductive hearing loss, sound is heard louder on the side of the affected ear. So in Rinne's test, normal air conduction is more than bone conduction, and conductive hearing loss, bone conduction is more than air conduction, and sensory neural hearing loss, air conduction is more than bone conduction, which is false positive Rinne test. And in Weber's test, normal we can heard in both ears, and conductive hearing loss, the sound will be heard in bad ear, and sensory neural hearing loss, the sound will be heard in good ear. Next question. A 30 years old male patient comes in the surgical OPD with pain, discomfort and swelling around anus and bleeding per rectum. History is suggestive of hemorrhoids. What will be the confirmatory test in OPD? So for hemorrhoids, what will be the confirmatory test? Options A, USG whole abdomen, B, sigmoidoscopy, C, proctoscopy, D, digital rectal examination. Answer is C, proctoscopy. Proctoscopy is considered confirmatory test for hemorrhoids, which allows the examiner to assess anus, rectum or lower part of the colon. Digital examination test or digital rectal examination is not a standard test to diagnose hemorrhoids, either external or internal. Next question. A 38 years old has come in emergency department with a ruptured gallbladder and undergone cholecystectomy. The patient is discharged with a follow-up instruction. After 2 to 3 weeks, the patient comes for follow-up in surgical OPD with the complaints of pain, abdomen, generalized tenderness in the abdomen, fever, etc. What would be the possible complication? Option A, peritonitis, B, gastritis, C, visceration, D, dehiscence. So patient is having fever, means there is a chance of having infection. So maybe peritonitis or gastritis. Obviously it will not be gastritis, it will be peritonitis. So the clinical features of peritonitis includes rebound tenderness, abdominal pain, rigidity and guarding which will be intense while coughing and sneezing, malaise, nausea and vomiting, increased temperature and neutrophils. Next question. To enhance the percutaneous absorption of nitroglycerin patches, it would be most important for the nurse to select which site. Option A, near the heart, B, non-hairy area, C, muscular, D, over bony prominence. Answer is B, non-hairy area. Whenever we are using patches, we should prefer non-hairy area, and we should also avoid distal part of the extremities because of the less maximal absorption. Next question. A patient in 28-week gestation is receiving labetalol and magnesium sulfate for her preeclampsia treatment. While checking BP, the finding is 8656. The most likely cause of this finding. Option A, false reading, B, accidental overdose of labetalol, C, magnesium sulfate toxicity, D, patient is anxious. Answer is B, accidental overdose of labetalol. So labetalol is an antihypertensive, which is a class of medication called beta blockers. It is coming under the category beta blockers. And how it acts is that it will cause the relaxation of the blood vessels and slows the heart rate to improve the blood flow and decreases the blood pressure. So if the blood pressure is decreased below the baselines, then it may be due to the overdose of the labetalol.